Hi everyone, welcome to Quarantine Clinics. Today is the 10th clinic of the series and we are discussing dementia. We have already covered myopathy, quadriparesis, hemiparesis, neuropathy so far, and today we'll be talking about what happens when there is loss of cognitive function in a patient. So all the cases that we have discussed so far and all the quarantine clinics we have discussed so far, it's always been about some deficit in your motor function. So whether it be your hemiparesis, your quadriparesis, your neuropathy, myopathy, even in your cerebellum, there is always some deficit in the motor function. So there will be some finding in your motor examination. But in your dementia case, your examination may be normal, your motor examination may be normal. So in a case of dementia, the main focus has to be on history, because it's the history that will give you a clear idea of what is the type of dementia and how to approach the case further, what investigations to make, and so forth. So let's understand what is dementia. In the most original sense, dementia referred to diseases of the mind. So, mentia is mind. Dementia is basically dementia, which is out of mind. Okay. So what that means is that in the early days, when somebody would behave out of their minds, they would be called as demented, and that is where the term dementia came from. So any person who would seem to be behaving irrationally or out of their minds would be called as a demented person. What this led to eventually, when we began to understand the disease of dementia, is that we finalize that any patient who has a cognitive function loss, any patient that has any problem in which their cognition is affected, so they are not able to do something that their brain is supposed to do, if they're not able to do that, then they would be called as dementia. Now, before we get to the history part, we need to know what are the cognitive functions. And I'm taking this separately because we have never covered this till now. So in your brain, there are certain functions that the thinking brain is supposed to do. Okay, so these are the cognitive functions, and there are a total of 6 cognitive functions. Okay, so the way I look at it is I go about it anatomically. So I go from the front and then I go backwards. So from the front, you have attention, which is in your frontal lobe, your prefrontal cortex. You have executive function, which is in your dorsolateral prefrontal cortex. Now, what are these two things? What is attention and what is executive function? Attention is obvious. If you are not able to be attentive, if you are not able to be in the moment and present in your task, you are not able to carry forward any task to the next. So that will obviously lead to some form of deficit. So if there is somebody who continuously loses attention, then they will appear demented because they are not able to take one action to the next. Okay, so if you are making chai, for example, and you pour the water and then you don't have attention, you will immediately forget that you are pouring water for chai. So then you will start breaking an egg, for example. So that is loss of attention. Now, suppose your attention is intact, you are paying attention, you do know what you want to do. Then you have executive dysfunction. Now, what is executive? Executive is all about plans, and it is about sequence of events. Now, again, so suppose you are making chai, you need to know what comes first. Do you put water first, or do you put the tea powder first, or do you put the kettle first on top of the stove? So your executive center, that is your dorsolateral prefrontal cortex, will tell you that first you have to put the kettle, then you have to pour water, then switch on the stove, then put the tea, so on and so forth. If you get the sequence wrong, even if you are paying attention, you won't be able to achieve your goal. So the second part after attention is executive, and that comes in your dorsolateral prefrontal cortex. Next, if you go back a little bit more, you'll reach the temporal lobe where you have language. And fourth is memory. Okay. Now, memory is also associated with learning. Now, these two things go hand in hand. Whatever you are doing or whatever you see somebody else do, so basically whatever you are experiencing, if you are not able to store it, and if you're not able to learn from it, you will not be able to put it to use the next time. So memory and learning is a very vital part of our growth. And language, if you're not able to take in any information, and if you're not able to convey whatever you want to somebody else, then again, there will be no growth. And so your overall goal of life, which is basically to achieve what you want to do, you need to be able to pay attention. You need to be able to have executive function, that is make a plan of action. You need to be able to learn from your experiences. You need to be able to gain information and convey information. Okay. Now these are 4 cognitive functions. What is the fifth one? The fifth one is in your parietal lobe. So that is just behind your frontal lobe. And this is your motor, procedural motor. So the procedural motor lies at the junction between your frontal and your parietal. So your the parietal will sense your sensations, and your frontal will execute your motor action. So supposing you want to make chai, you are paying attention, you have the plan, you have the sequence in your mind, you have learned from your past experiences. But when it comes down to it, how do you pour tea? How do you put sugar? So those are all motor sequences that you need to know. And suppose your motor sequences are lost, you won't be able to do anything. You won't be able to influence the environment. You won't be able to make chai. So if you think that your goal in life is to make chai, then you can see what all areas of the brain you need to make chai. So you need to pay attention, you need to have executive function, you need to be able to learn because somebody taught you to make chai, and they probably taught you using some language, and you need to have motor procedural skills. And the last one, the trickiest one to remember, is social cognition. Now, what does social cognition mean? Social cognition means the context of the environment, the context of the world. Now, you want to make chai, that is fine. But is it socially appropriate to make chai? So, what if you are not at your house? What if you are visiting somebody else's house and you just barge into the kitchen and start making chai? What if you're at a hotel? What if you're in a hospital? Is it the correct place to make chai? That is a specific human cognitive skill, but if any one of these cognitive skills are lost, the overall effect would be that you won't be able to function properly. Okay, so the end result is that you will not be able to make chai properly, which means that because of your loss of cognition, your activity of daily living is affected, and this is dementia. Okay, so again, let's go through it. Dementia is when your activities of daily living are affected because of a loss of cognitive functions.
What are the cognitive functions? These six: attention, executive function, learning memory, language, motor procedural skills, and social cognition. If any one of this is lost or one or more is lost, then the final end result will be that your ADL, your activity of daily living, will be affected, and that is dementia. Now, earlier, it used to be believed that dementia is only memory loss. So that is the concept that we all grew up with, and we all sort of remember that dementia is memory loss. But now that is no longer the case. Any one of these cognitive functions getting affected, leading to loss of ADL, is called dementia. Okay. Now, while we are on this topic, there is another concept called MCI. Okay. So MCI is basically when you have loss of cognition, but there is no affected activity of daily living. Okay, so MCI is mild cognitive impairment. So you have some cognitive loss. So if you test for it, you may find it, but your activities of daily living are okay. So the person is able to do everything from morning to night independently, and somebody who just spends some time with him may not say that there is anything wrong with this person, but on testing, it will come out. So this is called as MCI. And why is this important? Now let's look at how dementia and MCI occur in our society. So supposing this is age and you have 0 to 100, usually MCI and dementia. So let's take dementia first. If at the age of 50, 60, 70, 80 years and 90 years, MCI and dementia will be very less till the age of 60. Okay, so it will be like less than 5% of the population. As soon as you cross 60, 65, dementia starts to increase, and it goes around 10%. As soon as you cross 75, it crosses around 15%, and by the time you cross 85, it crosses above 50%. So it's around 40 to 50% of the population. Okay, so you can imagine that at 85 years, almost half the population has some form of dementia. Now, the reason that MCI is important is that before somebody reaches dementia, they usually have MCI. So if this is a normal person, before they reach dementia, they will usually go through the stage of MCI. And suppose if you diagnose MCI early, then we can investigate and start treating prophylactically if you find some cause for this dementia. So if you pick up MCI early, then you are able to pick up dementia, and you are able to even prevent or postpone dementia if you find some cause which can be treated. So this is why the concept of MCI is important, because as you know, in the older age group, dementia is one of the commonest diseases, and right now, especially in the developed nations, the maximum amount of money spent in healthcare goes into demented patients. So this is why that concept is important. Now let's come down to the clinical findings of dementia. So clinically speaking, we'll now discuss mainly memory. So out of the cognitive functions, we'll now discuss memory for a bit, and we'll discuss the types of memory, and then we'll go back to the overall concept. So when somebody comes with memory loss, this is the commonest complaint that somebody will come with, that मैं भूल रहा हूँ, मैं भूल रही हूँ, पिछले एक महीने से, पिछले एक साल से, since the last 1 month, 1 year, 10 years, I have started forgetting. Usually they won't come with memory loss of 10 years, they will come with the memory loss of a few months or a few weeks. But if you take a detailed history, you will find that there has been a slowly progressive memory loss since the last 5 years, 6 years. So this is the usual presentation of Alzheimer's disease. Now, what is Alzheimer's? I'll get to that later, but it is the commonest reason for dementia. Now, coming to memory loss, when you say memory loss, how do you approach? How do you ask questions regarding a case of memory loss? So you need to find out what kind of memory loss is it. So is it an immediate memory? Is it short-term memory? Is it long-term? Or is it a motor memory? Now, what are these different things? Immediate memory. So what is immediate memory? I tell you to go to the other room and pick up a key. That's it. I just tell you to go to the other room and pick up a key and come back. Now you go to the other room and you forget what was just given to you. That is immediate memory. So as soon as you hear it, you forget. What is short-term memory? Short-term memory is things that happened recently. What did you have for breakfast? What guest came home yesterday? What is long-term memory? Long-term memory is your remote memories. Where did you go to school? What were your childhood friends' names? What is your birthday? So these are all long-term memories. And what is motor memory? Things that you learn to physically do. For example, cycling, swimming, how to open a lock. All of these are motor skills that once you learn, you should remember. So these are all motor memories. So these are different types of memories. And why is it important? Why is it important to ask what kind of memory is gone? Because usually a certain disease will affect one of these. So a certain disease will affect either immediate memory or short term or long term or motor. Okay. So that will give you an idea of what kind of disease it will be. And two, different parts of the brain are responsible for different kinds of memory. So let's get into that. What are the different parts of the brain that are responsible for each one? So immediate memory is also known as working memory. And this is in the prefrontal cortex. So working memory, you can imagine as your RAM in a computer. Okay, so the RAM is the part of the computer that handles all the software applications that are open right then. So more the RAM, more softwares you can, more applications you can keep open at once. If your RAM is less, then your computer might crash. Your short-term and long-term memory are kind of hard disks. So your short-term memory is also called as episodic memory, and your long-term memory is called as semantic memory. So episodic memory are recent episodes. So what are the things that have happened recently? That is your short-term memory, and that is stored in your medial temporal. And long-term memory is your semantic memory. Semantic meaning there are associated emotions, that are associated meanings to those events. So the reason that you remember long-term memory is because you have attached certain significance to them. So long-term memory is stored in your lateral temporal. And your motor memory is also known as procedural memory. And this is stored in your basal ganglia and your cerebellum. Now, whoever had attended the quarantine Sunday clinics on both memory and language. Some of these will be familiar to you. So I'll just draw, so that's just to give you a basic idea of where these things are. Your prefrontal cortex is here. So this is where your working memory is. That is your immediate memory. Your medial temporal is here, and your lateral temporal is here. So your medial temporal will have your short term and lateral temporal will have your long term. And finally, your basal ganglia is somewhere here and cerebellum is here. And these two will have your motor memory. Fine. So step one to approaching a case of memory loss is asking which one of these, whether it's immediate, short term, long term, or motor, which one of these is gone. So as soon as you get that, you already have some sort of idea which area is involved, because as you remember, where is the lesion is the most important question. Once you know where is the lesion, then you can get to what and the why. Okay, so this answers where is the lesion. So in a case of memory loss, this is how you approach where is the lesion. Now, there are other ways to also approach where. For example, if your working memory is gone, then that will mean that there is something wrong in your frontal lobe. So that would mean that other things that the frontal lobe does may also be gone. For example, not just your memory, you may have loss of attention or executive function. Now, for example, if your lateral temporal lobe is gone, you may have also got loss of language. Okay. And if your basal ganglia and your cerebellum is gone, so if they have motor memory loss, you may have, if you remember your case of cerebellum, you may have ataxia, or if your basal ganglia is gone, you may have Parkinsonism. That is some form of movement disorder. Let's call it that. Some form of movement disorder, either a hyperkinetic or a hypokinetic. So yesterday we discussed approach to movement disorder. So there we discussed basal ganglia and why it is important for movement, but it is also important for motor memory. So if your motor memory is gone, you need to look for any kind of movement disorder. So that is how you put it all together. So that covers where is the lesion. Now we reach to what is the lesion. Now, when we talk about what is the lesion, the two main things you have to remember is that it could be hereditary or it could be acquired. And the easiest way to differentiate between these two is to ask for a family history. So suppose there is a strong family history, then it is more likely that the person has a hereditary disorder. So there is something in the brain that is going wrong, and that something is getting passed down from generation to generation. And in hereditary, what does that mean? Hereditary means that there is something in your gene that is causing your brain to stop working. And what that is known as is neurodegeneration. So neurodegeneration. So your brain degenerates. So your brain cells die. Because of some genetic problem, your brain cells die. Now, when they die is different. There are some genes that will cause it to die very early and some genes that cause it to die late. So, but whatever is the time, neurodegeneration is basically about your neurons dying by themselves. What about acquired? Now, the causes of acquired, there is a mnemonic called vitamins. And this is something we discussed in all the previous quarantine clinics. Vitamins stands for vascular, infectious, trauma or toxin, autoimmune, metabolic, iatrogenic, nutritional, and syndromic. And in this case, syndromic we have already covered in your hereditary. So this we won't take, but these are the causes of acquired dementia, acquired memory loss. And in each one of these, you can take further causes. So for example, vascular, you can have a stroke or a subdural hematoma. Infections, so you can have any brain infection, a meningitis or an encephalitis or a tuberculoma. Any one of these can cause memory loss. A traumatic brain injury, so boxers can have memory loss because of repeated injuries to the brain. That is called pugilistica dementia. Then there are toxins. So alcohol is a toxin, and chronic alcohol use can lead to memory loss. There are autoimmune conditions. So you have the immune cells in the body attacking the neurons. So that can cause dementia. Metabolic, so any of your metabolic dysfunction. So if your sodium level goes down or goes up, then that can lead to memory loss. Iatrogenic, so that is drugs. So if you have chronic sedative use, then that can lead to dementia. And nutritional, so there are nutritions that your brain needs, for example vitamin B12 or vitamin B1. So if there is deficiencies in these, that can lead to dementia. But the important thing is that all of these are acquired, and the beauty of an acquired reason is that A, it can be preventable, and B, once you find it, it may be treatable. So this is why it is very important to always look for an acquired cause of dementia before calling it a neurodegeneration. Now let's look at neurodegeneration. What are the reasons that can cause your brain cells to die? And the most important reason is Alzheimer's disease. So out of your neurodegenerative causes of dementia, almost 70 to 80% of your dementias are caused by Alzheimer's. What are the other kinds? One is something called as frontotemporal dementia. I won't go too deep into it, but there is something called Lewy body dementia and a vascular dementia, which can be taken in your neurodegenerative, or it can be taken as one of your vascular causes. So a vascular dementia doesn't happen acutely, but it is usually a chronic process of continuous stepwise clotting of different small arterioles. But your three main neurodegenerative causes of dementia are Alzheimer's, frontotemporal dementia, and diffuse Lewy body dementia. And out of these, your important one is only Alzheimer's. So when you think of neurodegenerative causes of dementia, you're thinking Alzheimer's. Okay, now let's just revise what we have done so far. A patient comes to you with memory loss. That's it. So that is where we started with. A patient comes to you with memory loss. You first have to find out, is it affecting his activities of daily living? So that means, is it a mild cognitive impairment, or is it dementia proper? Suppose he's saying that yes, it is affecting the activities of daily living. You need to look for what all cognitive functions are gone. So memory loss is there, but what about the other things? So for example, what about his attention? What about his executive function, language, learning and memory, his motor procedural skills and social functions? Now, once you have localized that it is only memory, suppose everything else is normal, then you will look for what kind of memory loss. Is it immediate, short term, long term? Is it motor? Once you have localized that, then you have an idea of where in the brain the problem lies. Then you will go into what could be the cause of this problem. And in the what, you will ask about family history. And suppose there is no family history and there is a history suggesting something in your acquired. So one of the vitamins, if you think that there is some problem, then you will go towards that. If suppose there is a strong family history, then you are going towards a neurodegenerative, a hereditary cause. And inside hereditary, the first disease you'll think of is Alzheimer's. All right, so that was all I wanted to discuss about approach to a case of dementia. Now we'll spend 5 minutes or 5 to 10 minutes just talking about Alzheimer's. Now, so far, is there any questions that you want to ask? Anything you want me to clarify about dementia itself? You can chat or you can unmute yourself and ask me directly. All right. So let's move ahead to Alzheimer's disease. So this was, I think his name was Alois. I think his name was Alois Alzheimer. He was a medical professional. He was in the earliest part of 19th century, I think 1906 or something like that. That is when he first described this syndrome. And initially when it was described, it was mainly memory loss. Now, of course, we know a little bit more. We realize that it's not just memory loss. There is also executive dysfunction. And later on, there is also motor deficit and social cognition is lost. So eventually, this is one of the key things about dementia. It doesn't really matter where it starts from, but eventually after 2 years, 10 years, all other domains are involved. So something may start off with just memory loss, but then eventually there will be executive dysfunction and then loss of attention. Something may start off with executive dysfunction and then eventually there'll be loss of memory, there'll be loss of language. So all these different sort of dementias are just classified on the basis of where they start from. But eventually they all look the same. So after 15 years, all dementias kind of look the same. Now, what is the pathology? What is the concept of Alzheimer's? So the basic idea is that your neurons are dying. Okay, so let's draw a neuron. So this is a cell body and this is an axon. Okay. Now, what happens is something is causing these neurons to die. Now, what is that? What are those things that are causing the neurons to die? There are two things. One is something called as amyloid plaques. And the other is something called as tau proteins. Now, I don't want to go too much into the depth of this, but the basic concept of amyloid plaques is that amyloid is a protein. And what happens is normally the brain, there is amyloid proteins that get accumulated in a normal brain. And as there is aging, there is more and more amyloid protein that gets accumulated in the brain. Now, in a normal scenario, this amyloid protein is supposed to get thrown out. So there should be a recycling system in which these amyloid proteins get thrown out. Now, suppose there is something wrong with this, or suppose there is, for some reason, more amyloid proteins are getting formed. Then what would happen is that these amyloid proteins sort of get converted into these hairpin loops. And what happens with these hairpin loops is that multiple hairpin loops get attached to each other to form something like a sheet. And then this sheet gets turned into itself, and these will form amyloid plaques. So it's a long process. You need amyloid proteins to accumulate, then you need these amyloid proteins to form these hair bands, then those hair bands will form the sheet, and that will form the plaques. And then finally, because once these plaques form, they will sort of wrap themselves around neurons and cause cell death. This is the basic concept of amyloid plaques causing neural death. What about tau proteins? So what are these tau proteins? I'll give you a basic concept. Again, this is the cell body and this is the axon. Now there are these cells along the axon called microtubules that help the axon carry nutrition. So the cell body is what is responsible for creating nutrition and sending that nutrition all the way down the axon. Now suppose something happens with this axon, that this nutrition is not being carried forward, then that axon will die and eventually the cell body will die. Now what tau does is, tau are these proteins that actually cause the walls of the axon, and something happens to cause this tau to misbehave. And long story short, because of this tau misbehaving, the axons don't function properly, there is loss of nutrition, and there is cell death. Again, I didn't want to go too much into depth, but this is the basic concept. There are amyloid plaques and there are tau proteins, and both of them come together to cause cell death. And when I say cell death, I mean neuronal death. And as more and more and more neurons die, slowly your cognitive functions start getting affected because they need those neurons to function. And the area in the brain where this cell death starts in Alzheimer's is an area called as hippocampus. Now, whoever's attended the memory lecture will remember the anatomy of the hippocampus. You can check it out there because it is a bit too detailed, so I didn't want to go again into it. But the hippocampus is the area. It's like a seahorse. So it's a structure that is shaped like this, shaped like a seahorse. And in this area, the neuronal death starts, and then it gradually progresses outward, and eventually it involves the whole brain. So in Alzheimer's, the first complaint that somebody comes with is a medial temporal problem, because hippocampus is in the medial temporal lobe. And if you remember, the medial temporal lobe is responsible for your short-term or your episodic memory. So that means that in Alzheimer's, the first thing that goes is your short-term or your episodic memory. So the classical presentation of Alzheimer's is that I keep forgetting what has happened recently, but I remember everything from my past. So even the relatives are all surprised that how can you remember things that happened in your school, but you can't remember what happened yesterday? But that is because they are two different memories and they're stored in different places. So what happened in your school is stored in your lateral temporal, and what happened yesterday is stored in your episodic memory in your medial temporal. So because Alzheimer's starts from your medial temporal, that is why your episodic memory is gone first. I think that's about it. That is the concept of Alzheimer's. Now, that should be enough for you to know how to approach a case. The rest of it you can read. You can read about what all investigations are. Basically, you need to rule out all your uh, acquired causes. So the purpose of investigation is to rule out your acquired causes, to rule out any treatable cause. So it is very important to rule out any treatable cause. So suppose you can treat that dementia by just giving antibiotics, for example, or you can treat the dementia by giving steroids if it is an autoimmune condition, or by just replacing whatever nutritional deficiency they have. Then that is your priority. More than diagnosing Alzheimer's, what you need to know is to how to treat a acquired cause of dementia. Okay, so all your investigation should be directed towards that, and the treatment depends entirely on the cause. So that all you can read, but this is the basic concept of approach to dementia and approach to Alzheimer's.